carriers of the same condition, that's when there's an increased risk. In this case, it's a 25% risk. There's a 50% chance that they would just be carriers, and there's a 25% chance that the child will not have either mutation from the parents as well. So, as Dr. Ling already alluded in the first talk, right now in Asia, we are screening for thalassemias, and it's a pretty effective screen. You don't really need to do genetic testing right now per se. We can just use complete blood cell or MCV with hemoglobin electrophoresis to identify those that are at an increased risk for beta thalassemia, also hint that it might be increased risk for alpha thalassemia as well. And so it's definitely a pretty effective screen, but if you're really screening for alpha thalassemia, why not screen for other diseases? Why have we not done this in the last 20 years? And genetic diseases are severe, right? It is the #1 cause of infant deaths. It does account for 20% of infant deaths, and accounts for 12% of pediatric hospitalizations as well. And from a public health perspective, the cost of adult survivors, they account for $2.5 to $5 billion. And even the World Health Organization mentioned that 1 in 100 children will be affected with a genetic disease. That's a 1% risk. So in the past, even when I was seeing patients, it didn't make any sense 5 years ago to offer multiple testing because it was very expensive. For every disease, it was additional cost. So if I wanted to offer 10 diseases for patients, it would have been $5,000 or more. So it does not make sense from a public health perspective as well. So in my perspective, I do think everybody should have the opportunity to screen, but really the issue is high cost, which I mentioned earlier, and also with slow turnaround time, especially when you're speaking with patients, depending on when they're doing this. If they're pregnant, time is definitely of the essence. And also, how do you articulate this to patients, right? These are, genetic information is complex, and how are physicians able to articulate it to them in a very limited amount of time? And with the cost of the DNA sequencing going much lower, faster than Moore's law, it is now feasible to offer that. And also, if you include that with innovative lab technology, you can actually offer affordable screening, but the other important thing is fast turnaround time, right? Because if it's affordable, but the turnaround time takes half a year or a month or two, it still does not make any sense to offer this to patients. And also, you still have to ensure that you can integrate this into the flow so patients can easily interpret that information, physicians can easily articulate that to their patients as well. So usually for expanded carrier screening laboratories, what they've done is they usually have to purchase the hardware and try to strip it down and rebuild this to ensure that it's more cost effective from a reagent perspective as well, because typically for reagents for next generation sequencing or for arrays as well, the reagents is expensive. So for laboratories, including ourselves, 1/3 of the employees are consistent engineers to help automate to ensure that everything is run in a robust manner and in a cost-effective manner as well. So why do expanded screening? Why should we really screen for more disorders? And in 2012, we've actually published a paper in Genetics and Medicine in screening for over 23,000 patients. And if you're really just following the sort of the most common prominent medical guidelines, in US it's known as ACMG or American College of Medical Genetics and Genomics, you will be missing 69% of carriers for these severe genetic disorders. And I'm going to talk a little bit more about what's actually in the panel, but we're not talking about what color the earwax is. These are severe conditions that patients would want to know about. They're just as bad as thalassemia, Down syndrome, or cystic fibrosis as well. And even if you just follow the guidelines commonly followed by obstetricians and gynecologists, also known as ACOG, you will be missing 77% of carriers as well. So this is actually significant. And in 2013 in US, the American College of Medical Genetics and Genomics actually did publish a guideline recognizing expanded carrier screening. They did recognize that this is important, although there's a few things you do need to consider. How do you actually inform patients about this test? Because you're screening for that many conditions, and physicians don't have an hour to talk about this test. And what diseases should you include? It's very important that you only include diseases that are very clinically important, like Dr. Wong alluded. It wouldn't make sense to include conditions where patients would not act upon that or they don't think that's significant. So even if you look at disease incidence, for all the healthcare providers here, I'm sure you're all familiar with open tube neurotube defects or spina bifida. The incidence on average is about 1 in 800. Everybody here probably is very familiar with Down syndrome. On average, the incidence is 1 in 700, although the risk actually varies depending on maternal age. So everybody's sort of screening for that, or is definitely aware of that. But if you actually collectively look at expanded carrier screening panel, the incidence to have a child affected with a disease on the panel is about 1 in 500. So that's even higher than Down syndrome or spina bifida. So why isn't really anybody screening for that right now? So specifically for the Counsyl's carrier screening, the family prep screening, we've designed this to only look at 102 genetic severe disorders, and we also have 5 optional diseases. One of them was G6PD, which is also included in the newborn screening in Singapore. We've tested over 250,000 patients, and specifically within these genes, we are only looking at 400 plus specific mutations that are known to be disease causing. And amongst the Asian ethnicity, the positive rate, the likelihood for somebody to be a carrier for any of these conditions is about 1 in 10. And I always want to remind patient physicians that we are here, statistically, we're all a carrier of something. On average, we care for 45 genetic conditions, but we're only concerned if both the female and male pollen from the same condition, and that occurs in about less than 1% of the time, or specifically about 0.6 or 0.8% of the time. So the reason why we're doing carrier screening is to identify the carrier couples, not to identify carriers, but really the carrier couples. So what's actually on our panel? So we do have conditions that do overlap with newborn screening. 59 of them do have limited to no treatment. Do have treatment options as well. So knowing earlier is better. A lot of them do overlap with newborn screening amongst different countries or different states in the United States of America. We do have 59 do have a shortened life expectancy. We do have 78 do have limited to no treatment options. And we do have 45 that do have a significant risk for intellectual disability, like Fragile X or Smith-Lemon syndrome as well, which I'll talk a little bit about towards the end of the talk. So one of the common objections I hear when I give this talk is, well, that's great. You've offered this test in US, which is primarily made of Caucasians, right? What about an Asian population? Have you identified any carriers besides beta thalassemia? And here's a distribution that I pulled up last month, specifically for Asians in testing for over 250,000 patients. So no surprise, you can actually see that we've identified some beta thalassemia carriers right here. But we've also identified a lot of carriers that would have been missed if you're only just screening for thalassemias. And some of these conditions that you might be familiar with, like cystic fibrosis, even when I was seeing patients in San Francisco, I usually tell patients that, well, the likelihood for you to be a carrier is about 1 in 90. So you don't really have to do that screening for long, right? Unless they really are concerned. But we've also found that the carrier frequency, it's higher than 1 in 90. And Fragile X is also another one that we've found as well. Connexin 26, also known as GJB2, non-syndromic hearing loss and deafness. It's actually a hereditary form of deafness, and a lot of other disorders as well, like spinal muscular atrophy, which in US, the American College of Medical Genetics and Genomics do recommend everybody to be screened for that. It is the most common cause of hereditary cause of infant death by the age of 2. So one of the other common objections I hear is, well, that's great. For those 400 specific mutations that you're looking at, that's based on published literature. And most of the time for these genetic disorders, these published literature are most likely referring to diseases that or mutations that are more common in other ethnicities, like ethnicities of Ashkenazi Jewish descent, of Caucasian descent as well. So that's why a year and a half ago, we've actually developed a screening assay through next generation sequencing. So in actually sequencing the coding regions of the genes of interest that we're looking at, you can actually maximize the coverage to ensure that this is beneficial for all the ethnicities, right? Let's use cystic fibrosis for example, since I mentioned that earlier. If you're offering a carrier screening through our original screen for that, for Caucasian descent, it's pretty accurate. It's about 90% accurate in identifying whether you're a carrier or not. But for Asians though, it's about as low as 65%, right? So it's not a really good screening test because we don't know all the mutations out there. But next generation sequencing, though, the detection rate, the ability to identify carriers, are just as accurate across all ethnicities. So that's the benefit of using next generation sequencing. And obviously, if you're using sequencing, you're going to identify more carriers, but again, remember the key is to identify carrier couples. We're all carriers of something. The goal is really to identify if an individual and their partner are positive for the same condition. So Taiwan alluded to this earlier as well. When you're doing sequencing, it's great. It's easy to buy a machine and start sequencing the genes of interest. But what are you going to be doing with that information? In the past, sequencing was utilized more for diagnostic testing, right? So given you're actually testing somebody that's symptomatic, there's an ascertainment bias because you're trying to look for something. So typically for when somebody is doing sequencing, what they have to do on the back end is when they identify a variant, they have to determine whether it's actually disease causing or not. And they have to go through a rigorous process and look through all the literature in the past to see what kind of supporting evidence there is. So there's a lot of literature that supports that this most likely is disease causing. Then it's classified as known deleterious. This is according to ACMG guidelines. If there's a few case reports, then that's known as likely deleterious. If there's no case reports, but this is a mutation that affects how the protein is built, then that most likely will be disease causing and is known as the predicted deleterious bucket. So I do believe that if we do identify patients with variants under these three classifications, we should be reporting that out. We would call that as a positive result for this carrier testing. But we definitely would not want to report out the variants of no clinical significance because we really don't know what that means right now. Or obviously the ones that are likely or known to be benign, most likely because of how common it is in the general population. If this variant we identify is common, is prevalent in 10% of the population, it's safe to assume that most likely that is not disease causing. And this is consistent with what other laboratories are doing in the diagnostic testing. So remember that the goal for offering next generation sequencing for carrier screening is really to identify carriers and carrier couples. So we're not trying to report everything under the sun, and that's why we're not reporting out the last three classes. And on average, every single patient would have about 9 variants of known significance across all the genes. So you're going to be freaking patients out that we are reporting that. It just would not make any sense. So I know I've told you theoretically less than 1% of cases will be identified as carrier couples. So what's actually happening? So these are statistics that I pulled up just in 2013. And you have to remember that there is an ascertainment bias right there. Just because I'm able to pull up the statistics because the male and the female are willing to merge the results. I actually know they're a couple. So amongst the reports that are merged, that are couples per se, we've identified 229 carrier couples. This is really the reason why we should be offering carrier screening to identify carrier couples. And no surprise, the top two are really the conditions that are sort of recommended by different medical bodies: cystic fibrosis, which is more common in people of Caucasian and Ashkenazi Jewish descent. Spinal muscular atrophy, though, has on average a carrier frequency of about 1 in 40. We have identified also 36 carrier couples for that. And we've also identified carrier couples that most guidelines are not recommending carrier screening for, like Smith-Lemmy-Open syndrome, which is actually a major severe disorder, which is caused by an issue in the cholesterol pathway, causing mental retardation and multiple congenital malformations as well. And we'll also identify, which I mentioned earlier, connexin 26, which is a non-syndromic hearing loss and deafness as well. So who should we really be offering carrier screening to? You definitely should not be offering this to newborns, right? The goal of carrier screening is to offer this to inform patients of the reproductive, or what the risk is for their future pregnancy. So definitely not to newborns. Most likely to individuals who are of adult age when they're of reproductive age, so in Asia it's about the age of 16. And ideally we want to offer this before they conceive, before they're pregnant. That's an ideal world. But for thalassemia testing right now, are you currently offering this in the preconception setting, or more likely are you seeing them when they're pregnant? On request. And so I think in an ideal world, definitely preconception is the way to go. in the US, unfortunately, most of the patients I see, they're already pregnant because they just don't like seeing doctors or healthcare providers. So we're really offering it here, but I think really in the ideal world, we do want to offer this conceptually. Because the earlier you offer this, the more options they have. The previous speakers, I've already alluded to that. If you're not pregnant yet, then you do have the option to pursue IVF or PGD. If you're already pregnant, the only other options are really to pursue invasive procedure to identify whether the pregnancy is at risk or not. And you should not be offering this to individuals if they decide they don't want to have children anymore. So you really should not be offering this to like an 80-year-old man or female as well, because that would not make any sense. So this is actually a very interesting survey done by obstetricians and gynecologists in the United States. It was actually a paper looking specifically at NIPT and expanded carrier screening adoption. So I'm only going to be talking about the expanded carrier screening part. But about 2/3 of the respondents did support the fact that universal expanded carrier screening should be offered. And then about 50% or half of them did say that, well, I most likely will offer expanded carrier screening if the patient asks for it. Which I think is always funny, because how would the patient know to ask for it when they've never heard about it to begin with? One of the common objections I hear when I speak to physicians about this is, well, isn't this too much information, right? You're screening for 100 disorders. How can I actually realistically explain this to my patients? And you really have to think about informed consent in a different way. When you're talking about thalassemias or even cystic fibrosis in the past, I would explain to the patient what that disorder is and then ask them whether they want screening for that. Now, though, even ACMG do suggest you should really do a broad level overview of the consent. And the best way to explain this to patients is that, again, realistically, we're all curious something, but we're only concerned when both you and your partner are positive for the same condition. That's when there's truly an increased risk. And a lot of times, patients will tell me, well, I don't really have a known family history, why should I be getting this? And there are many literature that support that. Amongst individuals that are born with genetic disease, 8 out of 10 or 80% of them do not have any family history. So most of the individuals born with genetic disease right now don't even have a family history. This is why you really should be doing screening. And given I'm a genetic counselor, I'm definitely biased in terms of the importance of counseling, right? So I believe that all laboratories right now do offer complimentary genetic counseling, which I'm very happy about. And I think it's depending on how complex the results are, physicians can easily articulate what the next steps are. For example, if a female is positive, then really the next step is to ask the partner to get tested. But if both the female and the male are positive for the same condition, then you might actually need the help of a genetic counselor, and most laboratories are supporting that right now. And that's definitely very important. So I want to end the talk with a case report that we've seen at Counsyl. So we saw a Caucasian couple who was doing this for the purpose of preconception, carrier screening. They had no children in the past, but they had multiple first and second trimester losses. And both the female and male elected to pursue simultaneous testing, doing our test at the same time. And it was surprising, but we did find that both of them are carriers for Smith-Lemmy-Open syndrome for different mutations. It actually surprised the IVF clinic, which was offering this initially as well. And so if you think about it from a generic standpoint, based on their ethnicity, the likelihood for a Caucasian couple to be affected with Smith-Lemmy-Open syndrome is about 1 in 40,000. So it's a fairly low risk. But obviously, after we've identified that they're both carriers, that doesn't matter anymore. Right? There's a 10,000-fold increase, given they're both carriers, there's a 1 in 4 risk now. And as a result, they did elect to pursue PGD. So for Smith-Lemmy-Open syndrome, I covered this earlier already, but they do have growth and mental retardation, cleft palate, cardiac defects as well, and other major malformations, and prenatal mortality could be up to 90%. And this is also interesting, because in our genetics medicine paper, we've also mentioned that in the past, we've always thought the carrier frequency, the likelihood for somebody to be carried for this disorder, is fairly low, about 1 in 130 or so. But we've found that it's actually much more common. It's about 1 in 68 or so. And most likely it's because the prenatal mortality is up to 90%. And there are multiple case reports and a few published papers that do support that.
impact as well.
And so, similar to Taiwan, I do want to end the talk by saying that really the reason why I personally do believe in expanded carrier screening is to identify carrier couples, because truly we will be benefiting patients by informing them and empowering them with this information so they can then decide whether they want to